So welcome to this third episode of this series, which is working with our wonderful colleague, Dr Shilpa McQuillan, who is a menopause specialist, a community gynaecologist, a former hospital gynaecologist also. So she brings a breadth and depth of experience that's absolutely brilliant. So we've had 2 episodes already. So let me recap. Episode number 1 was all about menopause myth busting. So that's been brilliant. I know that's been really helpful to people. Episode number 2 is about intimacy. Probably a greater experience topic for many people, but one that's less talked about. So we hope that that episode has landed well and is useful for you. So this next one is hugely fascinating, I think, for both of us, right, Shilpa? We both have South Asian heritage, which I love. I love the fact that I've got South Asian heritage, but with it does come some possible complications, as it does for anyone who possibly is perhaps of any other ethnicity other than white, because as we know, most of the data surrounding menopause has been done on white middle-aged women, usually in a higher socio-economic background as well. So we must say that too. So let's talk about ethnicity. So how is menopause different for different ethnicities? You know, as someone who sees people on a daily basis, how much is that in the forefront of your mind or in your personal or clinical experience?
I've really tried to think about this because I think there's been a couple of studies now, haven't they, been brought out and more and more research coming into this. But I've really tried to break it down. And I think there's 3 main categories, the way I put it. How menopause presents differently in different ethnicities. What are the long-term consequences of menopause that can also present differently depending on which ethnic background you are? And then what are the barriers to accessing healthcare depending on ethnicity as well? And I mean, this is such a huge topic. You might have to stop me because I'm just going to start, because otherwise we won't get going with it. But there's obviously, ethnicity is so broad. There's lots of different backgrounds. But I know the studies have mainly looked at people like South Asian, things like Afro-Caribbean and Asian. And there's still so much work to be done, because actually what the issues and not evidence or not enough research we've got is how much of this is due to our race, our physical characteristics, how much is to do with our actual socioeconomics, how much is to do with genetics, you know, because a lot of them overlap. You know, we've talked about, is it based on where we're from? Is it based on who we're in contact with? Is it actually based on pure genetics? And so that's what I'm going to hopefully go through now. Couple of things that they've really identified is that from some of these very limited studies, is that South Asian people tend to present with menopause early. Now, I interestingly went to the British Menopause Conference this year, Amantha, and the thing that got brought up was, and this is time and time again gets brought up, well, these women may not present or think it's an issue because they have their families early. Now, I was got invited to an Instagram chat quite recently, and I actually said, well, actually, I might flip that on its head, because I'm of Asian background. I'm very career-minded. No one told me I might go through an early menopause, and I hadn't had my children early. So actually, isn't it important we're bringing this awareness so that people, in particularly now, women are living longer, their careers are going on longer, and you're not aware that you might go through an early menopause and you haven't actually had your children early and you've left it. So I think equally important, it might not be that they might not present because they've had their children. What about the rest of the population who haven't done that? So let's use this as an opportunity to make aware to people that from, say, the South Asian background, you may go through an early menopause. Just keep that in the back of your mind when you're thinking about family.
Absolutely. So that was my reality. So I became perimenopausal, so that first stage of the menopause transition, when I was 36. It was less than 2 years after I'd had my daughter, and it would have been so helpful to have known that, really helpful. I'm not saying we would have wanted to have more children, but the choice and the opportunity was removed pretty swiftly because my, body stress. I mean, that's an important thing as well. I mean, ethnicity and genetics are one thing, but our environment does really affect how our genes express themselves. I'm a biochemist, so this is right up my street. So the reality is, you know, stress can really affect that genetics, you know, expression. So we need to be mindful of that, because you're absolutely right. Choice is so important. But if and certainly in the workplace, which is where I'm very much, you know, that's my area of specialism. In the workplace, if we're not putting information or increasing awareness for people, are we disadvantaging them? Because, you know, the reality is, why shouldn't someone like myself have it all? The reality was, I stepped away from work. I did that intentionally to have my daughter, first of all, but then I just felt I couldn't go back. And so that for me was, you know, I could statistically be one of those million women that effectively stepped away from work. But fortunately, I created a different career for myself. But the reality is, we stand to lose a lot of very talented, very capable people, potentially at a time where they could be having it all. They could be having families, they could be continuing with their career. And it's really important we don't have people stepping down or stepping out. So
interestingly, Amantha, you and I both know the new toolkits come out. And actually, one of the interesting things from that is, we've been basing what premature ovarian insufficiency or early menopause is based on the fact the average age is 51, and therefore going through early menopause is under 40. But if we're saying people, for example, from a South Asian background are going through early menopause, which is about 48, surely that means that for them, POI could be even earlier. Exactly. And we know that there are consequences, health consequences of going through an early menopause. So really, we should be saying that this awareness should be in schools and early 20s, 30s, really, for a lot of people.
Well, exactly. And so that is one of the great things about the aims of the menopausesupport.co.uk and the brilliant campaign Make Menopause Matter by Diane Dancebrink. Actually, from now, in all secondary schools, menopause is talked about as part of the PHSE curriculum. And if it isn't, you should be asking in your schools, where is that taught? Because someone like Shilpa could come in and do those talks, particularly if you're in the Berkshire area, because it is so important that we do educate people to understand what could be ahead in their timeline. So we've got a lot to get through then. So menopause symptoms present differently. We know that genetics, culture and environment, but let's get into that in a little bit more detail. So when we talk about the longer term impact of menopause, how does that affect ethnicities? Isn't it all the same, Shilpa? Don't we all cross the line eventually at the same place, with all great cardiovascular health, great metabolic health, etc.? Or is it different depending on your ethnicity?
Two factors come out of this. Firstly, if we're saying South Asian, for example, South Asian women go through an earlier menopause, we both know, what does earlier menopause hold for people? So that in itself is a risk factor for increasing risk of cardiovascular disease, so heart disease and stroke. It also increases risk of brittle bones and for deteriorating brain cognition. So if we're saying that that's already happening, then those women need to be more aware of these. You know, the government have brought out those health checks coming out. Need to be aware that actually those health checks probably are really important for those patients, in particular at an earlier age. What else do we know? I don't know if you had this experience, Amantha, but South Asian women are more at risk independently of diabetes, metabolic syndrome, high blood pressure, heart disease. So if we're then saying your early menopause is going to put you at risk of those, of that being Asian is going to put you at risk of those, how important is it that we are, you know, making sure that we're aware of these? I say this to you all the time, don't I? I say the words longevity, because for me, it isn't just about treating the menopause symptoms. It's ensuring we're providing those checks and those health checks and preventing heart disease and long-term health conditions for these women. And the only way we can do that is to ensure we're asking the questions and they're having these regular health checks, like checking your blood pressure, checking your bloods for diabetes and things like that.
Yes, absolutely. And so things like your cholesterol, we know, I mean, one of the first symptoms I got that I was in perimenopause that the doctors actually started paying attention to was I had a very elevated cholesterol level. And that's because your body's desperately trying to make you some sex hormones, because that's the basic Lego brick, if you like. Other bricks are available, but that's the basic brick for making your sex hormones. But it's also the basic brick for your stress hormone, cortisol. So often when we're seeing people or talking to people and they're going, yeah, I'm really stressed out and I don't feel great, I think it's the menopause, we've actually got two things going on there. So, you know, I'm quite lucky. I've got that warrior gene. So I've got quite a high threshold for stress, so I can cope with it quite well. But the reality is, if I've got high cholesterol, how's that affecting my cardiovascular disease risk? Because we had Dr. Vikram Talaulika on World Menopause Day talking about that and saying, actually, there is a window of benefit, isn't there, with hormone replacement therapy or menopause hormone therapy, whereby actually, if you get in that window, you're going to get benefits for the cardiovascular system and perhaps metabolic syndrome.
Lovely.
But actually, if you leave it much later, you're only going to get symptomatic relief. So are there any markers that people can look out for? And can we just define what South Asian is, by the way? Because a lot of people say to me, what is that? So what's the definition of South Asian?
Really good point. Yes, I mean, you know, Asian is such a broad term, isn't it? Yeah. So South Asian is your Bangladeshi, your Pakistani, Indian from India origin, and Sri Lankan origin as well. And it's very different to patients that are from, if we say Asia, patients like Japanese, Chinese, because they also present very differently as well. You mentioned about stress, Amanda, because that's one of the other things that's been found. And you quite beautifully said about, you know, is it something about you were saying about genetics, but use from the background of your degree. I always call it nature versus nurture. What part of it is nature? What is nurture? And one of the things found with stress and Afro-Caribbean patients is that they are more risk of something called allostatic loading. So this is where, and again, I don't know, I think more research needs to be put in of whether this is nature nurture, is that they found in their population, they were more risk of stress causing changes to their parameters. So if I explain it, allostatic loading basically is we've got a fine kind of equilibrium of where our blood pressure, our heart rate, our insulin sits. Now, when you're stressed, they go out of that range, don't they? They go up and down. Now, if you're chronically stressed, it can take a lot longer for that come back to that nice normal equilibrium. And the more stressed you are, more chronically stressed you are, that equilibrium or that normal can go out of range for you. So you're constantly trying to get it back to normal, but eventually that normal isn't there. And so they're at more risk of those parameters being their blood pressure abnormal, their insulin levels being abnormal. And that's what we call allostatic loading. And so that's one of the things from these studies was found about patients from Afro-Caribbean. But this is where I'm saying that you have to be a little bit careful, because how much do we know if that is genetics? Or where are they taking this data from? Because somebody who's South Asian, someone who's African, but are you taking it from England? Are they based in England? Are they based in villages in India and in Africa? Like, where are these studies being placed? Because I'm sure your allostatic loading or your stress is very different into where your environment you are as well.
Absolutely. But I would like to say people like Professor Joyce Harper from the University College London, she is doing great research into this, because she recognises there are gaping holes in this. I was lucky to be included because they're looking at things for like the National Menopause Education and Support Programme. They're looking to actually fill some of these gaps. And so I even know that there's a survey out already for Black women to complete, to talk about their symptoms. There's a survey coming for Asian women. I know that because we were looking at some of the definitions, because for example, Southeast Asian could be Indonesia, it could be Japan, it could be China. So it's really important that we do start to get the terminology right, and including actually, which I've learned something, people from Afghanistan are included in South Asian. So, you know, we have people moving, you know, it's much more transient now, the globe, the world. So we have people coming from all different places and existing, like you said, in different environments. So it is really, really important. So that brings me nicely then to ask the next question, which is, as a doctor yourself, and as someone with this rich heritage and an appreciation of some of the cultural barriers, difficulties, I mean, what are the barriers? Because there's quite a few, isn't there, Shilpa, when we think about this?
Yeah. And I think when we talk about this, I always feel sorry, because the question, when I get asked to talk about this, I always get said, you know, oh, I appreciate it's really difficult because I'm a white woman or I'm a white man saying this. But I want to say thank you for actually taking the time to actually think that this is an important discussion, and people shouldn't feel like they're treading on eggshells. No. And why I say that is because some of these barriers I do feel can be quite stereotypical. in some senses, but are really important that we address them. So some of the things I find, let's just say the obvious ones. What about language barriers? You know, if you go to your doctor, we say that you go to, so I'm a GP myself, so I'm not criticizing GPs, I'm saying from my own experience, this happens. You have a patient come to you, you've got a 10-minute appointment. It takes you 9 minutes to get on the phone for a translator, you know, let alone give them the time to talk about their list of menopause symptoms and forget the fact our last episode we just did was on intimate health issues. If you can't speak the same language, you've got 10 minutes and you brought your son to translate, are you really going to be telling me about your vaginal dryness? So again, is some of this barrier not because they present more with vaginal dryness, because that was one of the things that came from some of these studies, or they present lately, sorry, with those, or is it because they can't physically tell somebody what's wrong, or they don't want to because their son's the one doing the translating? So that's such an obvious barrier, isn't it? But yeah, it's massive. We have a massive, you know, I work in Berkshire. We have an absolutely massive South Asian population in Berkshire.
Yeah.
You know, what about patient leaflets? You know, we're real advocates now, aren't we? I've said to you, I've got lots of patient leaflets on my website, but of my own admission, I don't, yes, I'm from South Asian background, but I can't write Hindi or any languages, you know, or any, you know, we're not just focusing on Asian people, we're talking about loads of different ethnicities, aren't we? I don't have the ability to do that. And what we need, Amantha, and this is what these research, you know, like you say, like Professor Joyce Harper is amazing, is that we need to get that access where it's all centralized, where we've all got access. You know, people can write these leaflets in different languages and then everybody has access to them, because you and I don't need to write one leaflet in one area and someone down the road need to write it. We need a central reservation where all health professionals can access all of these.
Yeah, absolutely. Because actually something that Dr. Nagat Arif mentioned, which is actually some of the language for various anatomical parts or for the experience such as the menopause are so derogatory, because culturally that's just the way it is. You know, in some cultures, when you go through this time in your life, you're now seen as barren, surplus to requirement, over the hill, all of these sorts of things. And so actually, are we going to get people coming? And one of the really interesting barriers that we talked about is, you know, socioeconomic, you know, geography, you know, if someone's got to get 2 bus rides and they've got childcare to sort out, are they going to really present themselves, because their role as matriarch within the family home is to have the meals, etc. You know, I'm just sort of saying some things here, but it can be, those themselves can be massive barriers, as well as the language thing, can't they?
Yeah, and you've said that, but that's quite a well thought out barrier. Let's think even simply than that, a postcode lottery in our own country of where you can access HRT and help. You know, that's such a simple thing, and yet we have, don't we? It's such a postcode lottery, depending on where you live, where you're able to access these types of medications. It's all there.
Well, we live in Devon and we don't have a menopause clinic. We don't actually have a menopause specialist, just saying. But we do have the wonderful Womenkind Collective podcast, who are constantly beating down doors to try and get us a clinic, because 250,000 women are without a service here in rural Devon. We have one specialist in Cornwall. So it is totally disgraceful, you know, and we are largely forgotten about in rural areas. And I think that's the thing, you know, I think a lot of people, we're in a bit of a microcosm or a bubble thinking, oh, everyone's getting access to this, and they are not. So
yeah. I'd like to make another point, because that you've brought up a really good point there, because we're concentrating on ethnicity today, but let's not forget all the other, those registered blind, those registered deaf, those transitioning. There's so many different groups, those with disabilities. So we're covering ethnicity today, which again, we could cover for hours, which we don't have. But there's so many groups, isn't there, that we, you know, and I'm really glad that there's so many of us really passionate to do this. But I just want to throw that in there, because I don't want people to think that we're both, you know.
No. We're not two brown ladies. We're not two brown ladies talking about brown communities.
We are, because it's really important. But there are lots of groups, aren't there, that we you know, it's really great that we're trying to break down those barriers.
Yeah, and I can give reassurance. I was really humbled when I was at one of the working parties for the National Menopause and Support and Education Programme, to hear someone saying we need to have things in the right font so people who are partially sighted can see them. So people who you know, need extra assistance. Actually, if we're going to train people or teach people, how are we going to provide access into buildings for people. So this is a massive piece of work, but we're all committed. And the amount of brilliant people putting their heads together in their own time, not being paid to do this, but giving their time freely. I'm so humbled to be part of that. It's just absolutely brilliant. But we can still do things today, is what I'm saying. We don't need to wait for that. We can still do things today. So it's brilliant. So let's go into then, okay, so we understand there's language, socioeconomic, all of those sorts of things, and we know that we're going to address them. And we know that historical studies like the Swan study, you know, lots of these studies haven't really done justice to the disparities, but we know those disparities exist. Let's talk about then actually those physical differences then due to ethnicity. And one of the ones I find most fascinating, and I love talking about myself, is absorption and skin tone, texture, colour. Can you talk to us a little bit about that?
Yeah, absolutely. I've actually written that down as well because I didn't want us to forget to talk about this because it's so important. So when we are prescribing things like HRT, you wouldn't believe how much difference absorption can be between individuals. Now, we're concentrating on ethnicity, and I'm going to get to that in a second, but even just how hot you are, your skin, you know, if you think about when you're sweating, your skin pores are open, your blood vessels are nearer the surface. So you're more likely to absorb that gel, that spray, or the patch, which has the matrix in the glue. Where you are on your body makes a difference, how hydrated you are. And then let's get to ethnicity. You wouldn't believe that different people's skin turgor can be different in the type of ethnicity. And those people, and this is how the studies have been done, those are Afro-Caribbean, followed by Asian, followed by Hispanic, followed by Caucasian, is how it works in how least absorbed you can get from transdermal.
Could you say that again, please? Could you say that again so people who might be watching? So Afro-Caribbean,
South Asian,
yeah,
Hispanic, Caucasian. So such difference in absorption just in the type of not can make a difference. And then on top of that, we think about how these patches, and you know, I'm not criticizing because you know, obviously it's a great resource having patches. But if you think about, they tried to make them really discreet, but they're just one color.
Yes.
When you want to go on holiday in your bikini and you've got this great big white patch sitting on your bottom, and I'm just saying it to highlight that it, you know, there are lots of different things we could think about, you know. So difference in ethnicity might mean that we need to change the absorption or the amount of hormone in the matrix. Might be nice to change the color of them so people get that discreetness as well. Just little things like that are just things that, to me, I felt were interesting to highlight.
It makes sense. It makes sense. I went into a well-known retailer, and I was delighted to see a range of colours of period pants and underwear. So that's brilliant. I know the Wooker brand do lots, but the reality is we tend to go all black. And when I was a teenager, you know, it was either black underwear or white underwear, and that was it. But now we've got all the shades of skin tone. We've got different textures for different, you know, because underwear, I cannot stress enough how big a deal that is going through midlife. It honestly is probably one of the biggest considerations for people because it's next to our skin, isn't it? And one thing I would like to also add is I always put my Sandrina gel on my inner thigh, and I read the patient information leaflet and it said, oh, you can put it on the back of your shoulder or on the back of your arm. I stuck it there. I got the worst reaction ever. Like, it was like the alcohol in it just completely dried my skin, and it took 3 weeks to heal. So, you know, your skin, even different, like Shilpa saying, different parts of your anatomy, the one same person, your skin texture is really, really different. So it's important to pay attention to that. And I love what you said about the, you know, in terms of the different color patch. I mean, they do different color plasters now, don't they? Again, if you go into a high street retailer, you'll see appropriately colored plasters. And I think, well, we've obviously started then, haven't we?
Yeah, absolutely. Sorry, I'm going to have a bit of a giggle. You made me laugh because when I was at school, it was tights, and all you could get was white tights or black tights. I just remember being made fun of because I had the whitest tights on that obviously did not match my skin. So we've come very far, but it just made me giggle actually just thinking about that in my school uniform with my white tights.
Exactly. exactly. So so is there anything else? So yes, because, and I hear a lot of people also talking about like that whole stickiness and that reaction. And one thing that I do hear a lot from people that I speak to is, obviously we know people's levels of histamine can rise to be much higher during this midlife stage, and so things like irritation, red patching, hives type effects, you know, that's all telling you something. So if you do start, you know, don't, not to suffer on in silence and feel like you can't say anything. There are so many alternatives, aren't there, Shilpa? That
Absolutely. You know, there's a few things you can actually do. If you're, firstly, like you've just demonstrated, try a different area of the body.
yeah,
You can try a different brand. And then something a lot of people don't realize, and I'll be honest, I do still get GP surgery back their eyelids and ask me, did you really mean to say that? But a steroid spray, you know, an asthma spray, steroid spray is really good for local skin reactions. So, because not a steroid cream because it's wet and then things like patches won't stick on. But if
yeah,
you have a dry steroid spray that I prescribe for some people who have local skin reactions, it can really help people. So don't necessarily get disheartened that you've had a bit of a local skin reaction. Obviously, if you're having a full-blown allergic
yeah,
reaction, I'm not
yeah,
suggesting pursue it. But even if you're, because I have a lot of patients say, I really love the patch, I love the idea, but I keep getting this local little irritation, often things like that. Changing the site, changing the brand, or adding in a steroid dry spray can sometimes help.
yeah, exactly. So that's really important. So again, so the last thing that we've got here is some HRT might not be suitable for vegetarians, vegans, something to do with pork and beef. Can you explain a little bit more about that?
Yeah, so I mean, there's so many that I think what might be a good idea is if we put a link to this, because there was a really good article that came out in the Post Reproductive Health Journal.
Okay.
But if you get an example, things like Utrogestan, the body identical micronized progesterone, has a gelatin capsule.
Right.
And a lot of people don't realize that. And so, if, for example, if you're Hindu and you don't eat beef, if you're Muslim, you don't eat pork, or if you're vegetarian or vegan and you're not aware of all the different types of HRTs and which ones are suitable,
Yes.
you might be having these without knowing. So we can put a link for that, Amanda, because there was a really good article that highlighted all the different ones and
Amazing.
whether they're vegetarian.
Amazing. And one other thing that I wanted to mention, which was from another previous guest, which was Rebecca Brown from M Powder. I really liked that as a supplement. But what Rebecca said, and this is just something that other people should also think about, is if you are taking other supplements, you need to make sure that they're not going to interact negatively with your HRT, because not all do. So people, for example, taking black cohosh and various things. One of the things Rebecca was saying was actually their supplement has been tested to make sure it's not negatively interacting with your HRT. I mean, and that's something to be really mindful of, isn't it, Shilpa? Because we're bombarded by menopause products, aren't we, at the
Yes.
moment?
Absolutely. And not just that, a safety issue. People who've had, for example, hormone receptor positive cancers like breast
Yes.
cancer, there's a lot of supplements or products that contain things like phytoestrogens. And so we know that obviously if you're feeding it estrogen and you've got an existing hormone receptor cancer, you've got to be very careful. So please do your research and check those ingredients, because there are also, as well as there being, is the supplement working or interacting, it can be a safety issue as well for
Yes,
patients.
definitely. And actually a really good bit of news today, as we're recording this in November. I don't know if you even know this, Shilpa, you might not have seen it yet, but I'm sure it will come across your desk, that there's actually a drug which they're seeing that it's an aromatase inhibitor that actually they can give to women to prevent them. You know, you can have it for 5 years, but it will give you a much longer term protection against breast cancer. So it is wonderful. I know some of these things maybe demographically need to catch up because they are so out of date and so far behind, and actually they're marginalizing women as well. That's the thing that really gets up my nose. I did an interview with Pamela Windle talking about in Black History Month, and the reality is what we don't want is people going, that study says they're all going to get it earlier, so therefore we won't employ women from that ethnicity. That too much of that has happened already. This is about a level playing field. It's about equity, equality, diversity and inclusion. So that's why we need really robust, well-designed studies that capture all the information rather than maybe pockets of information.
Yeah. And actually, I'd like to point out with these things that women don't want to not work, but if we prepare ourselves, if we prepare, the best employees, and they're going to be more efficient, the more supported and looked after they are. And so actually, if we have this information and we can empower ourselves, give ourselves that information, our employers are getting that information, then we shouldn't be using it as a tool not to employ people. We should be using it as a tool to think, great, to get the most efficient employee out of somebody is to support them and be aware of what they might be going through, so that we can provide those tools or give them that support to go and get that help.
Totally agree. And that's exactly what we're all about, keeping women in work, because that's actually where they want to be. So for now, Shilpa, thank you so much. That's a great session, all about ethnicity. We'll put those links that you talked about to the study, talking about actually in terms of, religious and cultural beliefs, and how that might show up in the products that you might be using. But for now, thank you so much, Shilpa.
Nice to see you. Bye.